I think we're good too.
Okay.
So I'm starting off with this picture for, oops. Starting off with this picture for a couple reasons. So, you know, I've had the good fortune to travel a lot, and this was taken during one of my trips to Kenya when we were setting up HIV programs across Kenya. But this is in the Masai Mara, which is what you would call the Serengeti. And as you can see, there are two elephants coming toward you. And we were actually able to follow this group of elephants for several hours, and it was great fun. But the problem with an elephant, you don't want to get too close because, as my son says, unlike a lion, they don't need to get in the car. So this is when we got a little too close. You can see their ears are out and their trunks are up, and that's sort of a warning posture. And as soon as the driver saw that, he said, "Okay, let's go." But there's, you know, we're talking about a really big topic, opportunistic infections in HIV. And you know, sometimes it can seem overwhelming, but there's an African proverb that goes like this: how do you eat an elephant? One bite at a time. So that's what we're going to do. And we're going to start off basically by talking about what I call the 5 major OIs in HIV. And that is PCP, toxoplasmosis, cryptococcal meningitis, Mycobacterium avium complex, and CME disease, and not necessarily in that order. So if we go to our first slide, we're going to start off with a case. So a 32-year-old man presents with a 1-month history of progressive shortness of breath, minimally productive cough, fever, and weight loss. He has a temperature of 38 and an O2 sat of 94%. And what's interesting is, as you look at him, he's sitting there rather comfortably while he's talking to you. And this is actually a fairly typical presentation for PCP. And one of the things to keep in mind is when you look at how you approach respiratory diseases in HIV, is that the clinical characteristics really point you one way or the other. All right. So the most important thing with PCP is that it occurs in people with CD4 counts of less than 200. However, it's important that you be able to at least think about these things even when you don't have CD4 counts, because still today, in 2017, half the people who present with HIV present to the ER with their first opportunistic infection. So if it's rapid onset, less than 3 days, it's usually bacteria, you know, so the classic pneumococcal pneumonia, sudden onset of chest pain, a single rigor, fevers, chills, cough, tachycardia, looking septic, coughing up rusty brown sputum. That's very classically bacterial pneumonia. On the other hand, PCP and TB are more chronic pneumonias. In PCP, it occurs over weeks to maybe even a month or so. TB classically occurs from weeks to months. We don't live in a high TB endemic area, so we don't see it that often, but we still do. But how long those symptoms are really should be guiding you. So, you know, if someone gets very sick very rapidly, it's probably not PCP. On the other hand, if it's a slow onset and just gradually getting worse, then that should increase your index of suspicion. In terms of temperature, if someone is totally afebrile, they have a neoplasm. PCP, I've seen fevers all over the place. If it is purulent, it's usually bacteria, but PCP, there's very scant sputum. And in terms of a laboratory test, PCP does not classically give you a very large white blood cell count, and the LDH is increased. And so you can see LDH is, you know, between 600 and 1,000. One of the key things that helps out is if you have somebody and they're kind of coughing and they're short of breath and you're not sure, is to put a pulse ox on them and walk them around the clinic. And if they have PCP, they rapidly desaturate within the first, you know, 15, 20 steps. Now we have our nurses, they're really funny because what they do is they'll stick it on and they literally are doing almost competition fast walking around the unit. And they're just going fast, 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 fast. And people are going, oh, I'm so short of breath. You know, that would make me short of breath. So it just, you know, with normal type of walking, if you see a drop, that's another clue that this could be PCP. Now, so PCP classically occurs when CD4 counts are under 200. It has fever, dyspnea, dry cough, chest pain, Exam can reveal normal or diminished breath sounds. You can have some fine crackles, but typically you don't hear lots of wheezes. You don't hear lots of bronchial sounds. The chest X-ray has a diffuse interstitial infiltrate, and I'll show you an example of that. And chest X-ray may be normal up to 20% of cases. And here's one of those other things. Pneumothorax can complicate PCP in about 2% of the cases. So if someone comes in with a low CD4 count and a pneumothorax, PCP should be near the top of your list in terms of thinking, why did that happen? Now, if we go to the next slide, this shows you a classic X-ray for PCP. And in fact, at your first glance, you're looking at this going, wait a minute, what's wrong with this? And this is the kind of X-ray that if you sent it to the radiologist and you said, normal 20-year-old, they'd say normal X-ray. But if you said normal 20-year-old with HIV, they'd say PCP. So let's look at the elements that would push them that way. So here you see the hilum, right, and the heart looks pretty well. But as you start looking out here, you can start to see air bronchograms. And then look up here. You see how it's kind of hazy there? And there's like this interstitial pattern that shouldn't be there. And down on the bottom, you know, this could be normal, but down here, that's not normal. And all around here in the bases, that's not normal as well. And so a lot of times, what you'll do is when you look at the X-ray, you think, well, this looks okay. And you think about it, and you think about it, and you look at it a little more, and you go, maybe not, all right? And that's one of the problems, is that it can be difficult to diagnose by looking at the X-ray, all right? This is a chest CT, and so here again, what you see, this is the classic ground glass appearance, here, 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 here. You can see the pointers, right? Or no?
Yes, absolutely.
Yeah, okay.
Yes, sir.
Yeah, okay, good. Yeah, so this is the classic ground glass appearance. Now, how do we diagnose PCP in the 21st century? Well, quite frankly, a lot of times we do it empirically. If someone comes in, good CD4 count, good story, doesn't have a bacterial infection, then we treat them as though they have PCP. If they're sicker, we'll try and get sputum done. And for sputum, you basically need an induced sputum for PCP. And so just having the person cough and expectorate by themselves isn't good enough. You really have to get respiratory therapy to get your really good sputum sample. And in some cases, they even go to bronchoscopy. That's usually reserved for people that have very severe PCP and we're not sure of the diagnosis. But in most cases, we say, you've got HIV, you've got a low CD4 count, you have a syndrome consistent with PCP, I think you have PCP. Okay, so how do we treat PCP? Well, there is a wide array of things. This just lists the most common ones. So if someone has severe PCP, and by severe we would use the same criteria for severe pneumonia. This is somebody, you know, clearly short of breath, clearly coughing, somebody you want to put in the hospital, all right? And then in those cases, your choices are trimethoprim sulfa or Bactrim or pentamidine. Now, trimethoprim sulfa is dosed on a milligram per kilogram basis. It's basically 180 milligrams of trimethoprim per kilogram. And in the hospital, we give that to them intravenously on, you know, about twice daily, sometimes 3 times daily, depending on how big the dose is. For people who have Bactrim allergies, and there is about 25% of the people with an AIDS diagnosis have a Bactrim allergy. And the reason this occurs is because as your CD4 count declines, you lose the ability to regulate your immune system. And so we see a lot more drug allergies as CD4 count goes down. So in those cases, we use a drug called pentamidine. And pentamidine, again, is given intravenously. It's a drug that can cause kidney failure, and it's also a drug that can cause severe pancreatitis. And I swear, in my 30 years of doing this, I can't recall a single person that's completed a full 21 days of pentamidine. Usually they start getting better and they start having toxicity and we find something else to treat them with, all right? So this is going to be for your hospitalized patients. The other thing to remember is that dapsone, which is sometimes recommended for people who have a Bactrim allergy, there is a cross-reactivity about half of them, so you got to be a little bit careful with that. So for mild to moderate PCP, and by mild to moderate PCP we'll get to in just a minute, it's the #1 drug against trimethoprim sulfa. For people who have an allergy, you can use trimethoprim dapsone, you can use clindamycin primaquine, or you can use atovaquone. Now, it used to be that this combination, clindamycin primaquine, in outpatient setting was used a lot because it was dirt cheap, but now the price of primaquine has actually gone up a lot. And it's one of these scenarios where the makers of the generic drugs realize they can jack up the price and get away with it. And so that getting drugs for your patients based on cost is something that that you do have to be aware of. Atovaquone is a really very nice drug to use. It's given twice a day. It's very non-toxic. It gets absorbed well if you have a fatty meal. So we used to joke and tell our patients, you can have your atovaquone in a pizza twice daily. Or if you want to substitute a cheeseburger for the pizza, that's okay. But you need a high fatty meal. But your number one drug is going to be trimethoprim sulfa. Now, when we say mild to moderate, what do we mean? And basically, what that means is that people who are, one, they can take PO, two, they're not so severely hypoxic that they need to go into the hospital, and three, looking at this PO2, if their PO2 is above 70, that's a good cutoff to use. Now, the third part of the recommendation for people with PCP is to treat them with prednisone if their PO2 is less than 70. Why is that? Well, early on we learned that we were treating people with trimethoprim sulfa. They'd get better for 2 days and they'd suddenly get worse, and nobody knew why. And they'd end up getting ventilated, and some people died. And the answer turned out to be is that this was an immunologic reaction to the killing of the PCP by the trimethoprim sulfa. And so by giving them prednisone, what happens is that you blunt that immune reaction and they recover quite nicely. Now, a lot of people were very worried that by giving people prednisone, we would make them more immune suppressed and bad things would happen to them. But the answer is it doesn't happen. Occasionally you get a little bit of outbreak of herpes around the mouth, but for the most part, people do just fine. And then there's a question that shows up on the ID boards, and I always ask the ID fellows this, is at what stage, mild, moderate, or severe, is prednisone been shown to be beneficial? And the answer is in all stages, but it's one of those sort of risk-benefit type things. So, for example, in mild PCP, somebody comes in coughing a little bit, has a chest x-ray, walk him around, he desaturates, but otherwise looks good. If you give him prednisone, what's going to happen is a year later his PFTs will be better than if you didn't give him prednisone. But he's not going to have much of a problem without the prednisone. In moderate PCP, same thing, but in moderate PCP, they're less likely to progress to severe, and in people who have severe PCP, they're less likely to be on the ventilator, and if they're ventilated, they're much more likely to get off the ventilator earlier than if they don't have it. So at every stage, so I guess it's the way of saying, even though this number here is 70, that you can use judgment with that. You're not going to harm the patient by giving them prednisone. You may benefit them even if they have mild PCP. So if you're going to make the wrong call, make the call on the side of giving them prednisone as opposed to making the call of not giving them prednisone, because that's where they're going to get in trouble. Okay, what are some of the toxicities we see with this drug? Well, with Bactrim, it decreases your white cell count, it decreases your platelet count, it decreases your LFTs. It can actually increase your creatinine, and that is actually not, well, there are two reasons why it does that. One, it interferes with the secretion of creatinine into the tubules, but it also actually can cause damage to the glomerular filtration if it crystallizes out. Occasionally you get a rash. Actually, I take that back. You can get a rash a lot of times. All right, this is probably the most common reaction. And occasionally you get fever. With pentamidine, there's a whole host of things. I would not recommend using this without having an ID consultant on board with you. With clindamycin, again, you get rash. You can get methemoglobinemia, the same thing that you can also get with dapsone. And this is because the hemoglobin gets methylated, and it can actually be a little bit deceiving, because someone will come in and they don't look good. They look like they're not feeling very well, and they may be a little short of breath. And you stick a pulse ox on them, and their pulse ox is normal. It's 95% saturated. You're going, what's wrong here? Well, that's because what the methemoglobin does is it binds to the oxygen binding site. So when you put an O2 sat on them, it reads as saturated. But if you were to get a PO2, you'd see the PO2 is very low. So if you have a patient either on primaquine and clindamycin or on dapsone, and they have those problems, definitely don't just stop at getting a pulse ox, get a blood gas with them as well. And then you can use dapsone, but typically for treatment of PCP, we usually use dapsone with trimethoprim as well, okay? One of the big issues that people are always concerned about with dapsone is hemolytic anemia in G6PD deficiency. And that is a real thing, but there's actually two types of G6PD deficiency, okay? There's the hemolytic anemia that we all learn about, where if you give people dapsone or if they have fava beans and they live in a Mediterranean area where they almost die because they have so much hemolysis. There is a sub-Saharan African variant of that where they will have, they may have some mild hemolysis, but they rarely get really sick. So, you know, if one of the questions I like to ask the fellow, who's most likely to, you know, to get hemolytic anemia from G6PD deficiency? And if there's anybody on the team who's either an Arab or from Sicily, you know, it's always fun because they all want to point to the black guy, but they're all kind of embarrassed to point to the black guy, so the black guy has to raise the hand themselves, you know, say, hey, it's me. And then we go, no, it's not you, it's him. And then and you point to the person who actually is in the Mediterranean area, all right? Doesn't mean it doesn't happen, doesn't mean you don't need to be aware of it, but primarily, you know, in treating African-American populations, it's not as big a deal as you would think would be just reading the textbooks.
Right.
Okay. So this is Lake Nakuru. This is north of Nairobi, and this is where they literally have millions of pink flamingos. And this just gives you a close-up view of that. You can see them reflecting off the lake, and it's really quite beautiful. Although when you get out of the vehicle and you will start walking toward the lake where you see these animals, the first thing you notice is this hum, this very loud, and you think, what is that sound? And what it is, it's, imagine a couple of flamingos going, and multiplying that times a million. And that turns into a big hum. And you don't realize it until you get close enough to hear the individual sounds. So things always aren't as they appear to be. Okay, so our next case is we have a 34-year-old man who's been HIV positive for 10 years, and he's brought to the ER after a witness seizure. He's been receiving antiviral medication until 5 years ago when he stopped taking his medicine. His family members report that he's had some memory loss and unusual behavior for the past 2 weeks. On PE, he's confused and disoriented. So the question is, what's he got? All right? And basically, when someone with HIV comes in with a change in mental status, several things you have to think about. One is toxoplasmosis. Another one's lymphoma, a CNS lymphoma. And the third thing is do they have cryptococcal meningitis? All right? And right now, based on this history, you can't tell. So the normal drill for someone who has comes in with a change in mental status is to get a contrasted head CT or an MRI scan. All right. Now, typically what happens is when people hit an ER door and they're confused is they get a non-contrasted head CT, and there's a good reason for doing that. You know, when someone comes in, they're looking for bleeds, they're looking for head trauma, they're looking for midline shift, and a non-contrasted CT will tell you all that. But what it won't tell you is whether they have an infection. And so the classic way that toxoplasmosis presents is that they have a ring-enhancing lesion. See? Here's one, here's one, here's one, here's one, here's one, here's one, here's one. You're seeing them all over the place. Multiple ring-enhancing lesions. And that's toxoplasmosis until proven otherwise. Where it gets more confusing is when you get a scan and you see this. You see this lesion? It's huge. You can see it on several cuts. It's causing significant midline shift. You see right down the middle there. It's crossing the middle. And look all here. You see that? That's all edema around there. So it's causing a lot of edema and causing this person a lot more problems. Is this toxoplasmosis or is this lymphoma? Well, there's some ways that you can try and figure this out. All right. So first of all, radiologically, we can't tell. There's no way we can tell when we have a single mass lesion, all right? If they have some extra CNS lesions, sometimes that's helpful, particularly, again, if you're in a high TB area. we can get serology for toxoplasmosis, all right? And that is basically you get toxo IgG, okay? And if the toxo IgG is positive, that increases your suspicion that the person has toxoplasmosis if they have a single lesion, all right? But I can show you case reports dating all the way up to about 4 years ago of patients having a negative toxoserology, but on biopsy having toxoplasmosis. Then you go look for a wide variety of other things. You get a cryptococcal meningitis. You look to see if they have AFB. You can look for histoplasmosis. But a lot of times what it really comes down to is this, is empiric therapy. Okay, so as we go back to this case, we ask ourselves, how bad is this guy? Do we need to get a biopsy right away, or do we have time to treat him empirically for toxoplasmosis to see whether he improves? And that's a decision that really has to be made in conjunction with neurosurgery. And the reason why I say that is if his lesion were right here, they could stick a needle in easily. But look, this is pretty deep, you know? And some neurosurgeons will look at that and they'll say, yeah, not a problem, I can biopsy that. And other ones will go, I don't know. I don't know if we can do it or not. I don't know if we can safely do it. So when you get a biopsy, when you see something like this and you're not confident in what it is, you should always consult a neurosurgeon and see whether they think a biopsy is something that they can feasibly do. Okay? So how do we make the diagnosis? Well, again, the definitive diagnosis is with a biopsy, all right? But that's almost never done. So even though you'll read that in the textbook, you almost never see it happen. Having a low CD4 count, under 200, under 100, makes you even more concerned about toxoplasmosis. Having a comparable neurologic disease, what does that mean? And the answer is that it means that they have something that either shows a mass lesion or they have multiple lesions that you can't explain by a single lesion. You know, again, that's consistent with toxo. One of the third things is that if they don't have prophylaxis against PCP, that's a very important thing because, and we're going to talk about prophylaxis in another lecture. But you know, for if someone has a CD4 count of under 200, it's recommended that everybody get on Bactrim. And not only does that prevent them from getting PCP, it prevents them from getting toxoplasmosis. It also helps prevent them from getting malaria and all sorts of traveler's diarrhea. So it's a good thing to do. But if they're on no prophylaxis, your index of suspicion is higher. And then if they have a positive toxo IgG, then it's even higher. So low CD4 count, no prophylaxis, positive serology. This CT scan, that's toxo. This CT scan, we think it's toxo. We're going to empirically treat him. We're going to watch him. If he starts to deteriorate further, we'll give him steroids to help with the mass effect. And if he's not better in several weeks, then we'll really ask the neurosurgeon to go ahead and biopsy it. Okay, how do we treat it? So the treatment for toxoplasmosis is sulfadiazine and pyrimethamine. Okay, pyrimethamine has been getting very expensive these days, and this is the drug you've all heard about with that guy Martin Scarelli, where they're charging a ton of money for it. The good news is that because the company jacked up the price to where it was about $1,000 a pill and they got such bad press, is they had to do penance. And the way drug companies do penance when they overcharge things is they give it to ADAP for free. So I can tell you, we have this drug on ADAP, and it basically costs $1 for 30 pills. So you know, you basically get it for nothing, and you get them registered for ADAP. An alternative regimen, if people have fever, if they have an allergy to sulfa, would be to use clindamycin plus pyrimethamine. Now, down here you'll see a list of things that are less studied, but I'll tell you, what's really rising, and you won't see this on any treatment recommendations in the United States yet, is Bactrim. And it's been shown pretty well in sub-Saharan Africa that if you use high-dose Bactrim, they never use sulfadiazine. If you use high-dose Bactrim, you'll get good results. So while we were having trouble getting pyrimethamine, we used trimethoprim sulfa in some of our patients and with really, really good results. Okay, so these are the kind of options that you have. This is still number one. We still have some access issues with this. This seems to work just as well although there's no head-to-head studies of it, and there's not as good data. Okay, this is just a picture of a lion that I took, and I love lions, so I wanted to show it to you. Anyway, so this is not case number 1, this is case number 3. A 28-year-old woman with AIDS and a CD4 count of 32 comes in and complains, I can't see. What's the first thing that comes to your mind?
28-year-old, you know.
Cordella says CME.
CMV.
DME?
Right. That's the first thing that should come to your mind. Guess what? 97 times out of 100, they're not going to have it. But it's still the first thing that comes to your mind. Why? Because if you miss this one, people go blind. All right? So don't have any apologies if someone has a low CD4 count of under 100 and has vision problems. They need an ophthalmologic diagnosis, and I'll get to that in a minute. So this is the normal retina, just to kind of get you oriented. And here you see the optic nerve, and you see the retinal arteries, and you see the retinal veins, and here you see the fovea. And this is what a normal retina looks like. This is what CMV retinitis looks like, okay? It's been called cottage cheese and ketchup. Here's the cottage cheese. Here's the ketchup. Why anyone would put ketchup on their cottage cheese, I have no clue. I don't like cottage cheese, so, you know. But basically what you're seeing is you're seeing massive exudates and you're seeing hemorrhaging, right? And if it gets, here we are right at the fovea, right? Remember here? And you can see that there bleeding into the fovea. And if that happens, they're really in grave danger of losing their sight almost immediately. And so the big key in CMV retinitis is to get an ophthalmologic exam. You notice, you can see me, right? So, you know, big O, not me. If I can see it, it's really bad, okay? But we really need within 24 hours to get an ophthalmologist to dilate the eye and look under a slit lamp. Most cases today in the 21st century probably won't have it, but we still have people who have CMV retinitis. And so it's very important to make that diagnosis. So when you have CMV disease, the eye is the area we worry about the most, but you can also see people who have colitis. This is where people have HIV and they have just diarrhea that just goes on and on and on and on and on, and you send all the pathogens, you know, from their stool and send stool studies, and it goes on and on and on and on, and you get GI to scope them, and they say, oh, it just looks like there's colitis everywhere. Have you thought about C. diff? So you treat them for C. diff, and then they call you up a couple days later, and they said, oh, we got the biopsy back. It's CMV. Okay? And that's not an unusual course of things. It's unusual that you make that diagnosis right away. But these are your two big things with HIV. Pre-heart, about 30% of them now. It occurs very rarely if we get people on drugs. All right. Sometimes it causes a pneumonitis, although in HIV patients it's very rare. It's much more common to see in people that have who are transplant patients. You see the pneumonitis, but you do see a ventricular encephalitis, and I think I have a scan of that in there. And then you can get a radiculopathy as well, and that's where people come in and they just lose their ability to walk, and it's primarily their lower extremities. It's in the sacral plexus. They have problems urinating. Either they can't urinate or they're incontinent. You do an LP on them, and you find some very interesting results. You find lots of white cells, mostly polys, which suggests a bacterial infection, and a low glucose. And most people say, oh, that's a bacterial infection. Guess what? In an HIV patient with a low CD4 count, it's not. It's not bacterial. It's CMV. But these are the ones I really want you to know about. And really, you know, just if a patient comes in saying they can't see, get them seen. All right? How do we diagnose it? Well, you can use serology. All that tells you is whether someone has been exposed to CMV, and most of us have at some point in our lives. And you know, so CMV can present as a mononucleosis, and it really depends on how you grew up. You know, if you were poor when you were growing up, you probably had it when you were 5 or 6, and if your family was more middle class or more affluent, you probably didn't get it till you were about 15 or 16 and went on dates and started making out. But it presents as a mononucleosis. You can find viremia in patients who are asymptomatic, But in HIV-infected patients, it hasn't been shown there's any benefit in treating these people. So, you can send off a PCR, but it doesn't really help very much. Histology and it really helps in terms of colitis. That's where you need the actual biopsy. And in retinitis, we basically wait for the ophthalmologist to tell us they have it. An ophthalmologist tells me it's CMV retinitis, it's CMV retinitis. Okay. Sometimes we disagree. If their CD4 count is 800, you just have to remind the retinologist that their CD4 count is 800. This almost never happens with someone's CD4 count that high. What else could it be? And that happens occasionally, but not very often. All right. So that's kind of how do we treat? I don't have a thing on how to treat CMV. I'm sorry. I accidentally hid the slide on how we treat it. So the way we treat CMV retinitis in the 21st century is two ways. One is with ganciclovir, given IV. So it's like acyclovir, but it's a little bit different. It's a guanine derivative, and it is active against cytomegalovirus. And that's given on a milligram per kilogram basis IV. But the best treatment, if it's in the eye, is to have intravitreal injection. And that's probably one of the most important things, is to have the ophthalmologist inject ganciclovir directly into the vitreous. And what that does is that gets super therapeutic levels right at where the infection is as soon as the injection is done, and people have the best outcomes with that. We still continue to give them IV ganciclovir, but getting that intravitreal injection really is one of the most important things. One of the complications that can occur is that people can have a retinal detachment. When you inject, they can have a retinal detachment. But the studies have shown is that the rates of retinal detachment are not related to whether they have an injection or not. So if you don't have the injection, you can still get a retinal detachment, except it will occur later. It will occur 2-3 weeks into the illness. If you have an injection, they can get a retinal detachment, but that retinal detachment will occur within a couple days of the illness. Okay. So this is a monkey consulting with an artist. You can decide which one's which. But this, again, was taken in Kenya. That was my son. He actually had mono. It was so funny. He came home from school on spring break with his throat swollen so tight he almost had to get intubated. I mean, he was really sick. And he ended up in the ER. And they gave him steroids, and it just melted away, and it looked like he had mono. So I had to have one of these father talks, and I had to say, Sam, I need to know this, okay? He goes, no, I haven't done anything. I haven't had sex with anybody. There's just this girl we made out with, and that was a long time ago. It was Valentine's Day, and I'm counting that 6 weeks. That sounds just about right. And it turns out he had CMV. So, so as a father, seeing my son have his first example of, or first encounter with a sexually transmitted disease, I'm glad it was cytomegalovirus and not something like syphilis or gonorrhea or HIV.
Right.
So our next case is a 40-year-old man with AIDS whose last CD4 count was 150. He was lost to follow-up. He now presents with fever, weight loss, and diarrhea. On physical exam, he's hypotensive and he's very wasted, and his temperature is 40 degrees. Okay? So this is a very classic presentation for Mycobacterium avium complex. So MAC infection, oops, going the wrong way. MAC infection is a cousin to tuberculosis, and it tends not to cause as severe disease. It can get in the lungs, but it also can be in water. And when people drink infected water, it goes across the GI tract, it gets taken up by the liver, and then they have bacteremia, and then after having bacteremia, they develop disseminated disease. So then they have MAC in their bone marrow, in their liver, in their spleen, and their lymph nodes. And what happens is that as the MAC grows, sometimes it spills over into the bloodstream from the bone marrow. And then there's more MAC, and it spills over more and more. And every time it spills over, they get a fever. So they have intermittent fevers, okay? And because it's in their GI tract, they have diarrhea. And as their burden grows, that fever then becomes persistent. The diarrhea becomes persistent. A couple things that we see classically on the lab tests of MAC is they have an alkaline phosphatase that's elevated out of proportion to the rest of their liver function tests. So instead of having an AST, and their AST-ALT may be 40 or 50, and their alkaline phosphatase may be 250 or 300. they can be severely anemic. In fact, they can be pancytopenic. So a hemoglobin of 7 or 8, a white count of 2 or 3, a low platelet count of less than 50,000, not uncommon. I keep accidentally hitting this, I'm sorry. Okay, those are not uncommon. So how do we make the diagnosis of MAC? Well, the first thing is a compatible clinical syndrome, and then we isolate MAC, and most typically we isolate it from the bloodstream, all right? And if the patient is symptomatic, you can get a positive culture in as little as a week using a BACTEC system. This is liquid media. Getting it from stool or sputum, you can get it there. It's a pretty low predictive value, but on the other hand, if someone has it in their sputum and they're sick, then you go ahead and treat them. How do we treat them? It's really easy. You use a macrolide antibiotic and a ethambutol, okay? My preference is to use azithromycin, which is given at 500 or 600 milligrams a day, plus ethambutol, which is given at 15 mg per kg, and you just use those two, and they do fine, okay? Now, because they took a long time to get that sick, they don't get better immediately. It's like treating a person with tuberculosis. They don't get better overnight. It can take weeks for them to start feeling better, for the fevers to resolve, for the diarrhea to resolve. But you keep treating them, and you keep treating them, and you keep treating them, and they get better. Why azithro as opposed to chlorithro? Well, chlorithro has more GI side effects, and you have to take it twice a day. And so you'll find that some patients can't tolerate the clarithromycin. So azithro seems to be a better choice. After we've treated people for 6 months to a year, and their CD4 count is above 200, you can actually stop treating them, and they do well, which is really amazing, because when I first started doing this, the dictum was you keep people on these therapies for the rest of their lives, but you don't have to do that. But the main thing is to recognize it, see, oh, this guy's wasted, he's got fevers, does he have tuberculosis, does he have MAC, does he have histoplasmosis? Those are the big three that you worry about in this, and then do the proper test, and if they have MAC, then treat them with these two drugs. Okay, our last case is a 22-year-old gay man presents obtunded. He's febrile at 39 degrees. He has no stiff neck. He has an LP done. He has normal glucose, normal protein, and 8 white blood cells in his CSF. So if you didn't get that this guy probably has HIV, you'd say, gee, I don't know what's wrong with him. But if you think he has HIV, you'll say, oh, he has HIV. Does he have toxo? Does he have cryptococcal meningitis? And the answer in this particular case is that that's a very classic presentation for cryptococcal meningitis. So the epidemiology of crypto is that their CD4 count is less than 50 cells. They have a positive cryptococcal antigen, and you can get this 2 ways. You can get it through the CSF, you actually do an LP, or you can get it from blood. And in sub-Saharan Africa, this is the way it's done most of the time. As ID people, we like everybody to get an LP, but it's interestingly, you'll find it more common or as commonly in the blood as you will in the CSF. Blood cultures are only positive about 70% of the time. One of the things that is a poor prognosis is they have a poor mental status and a low white blood cell count. Now, how can you have a poor mental status and a low white blood cell count? Well, there's a couple. There's a very important thing to realize, is that their immune system, their CD4 count, is so bad they can't mount an immune response. And what's white cells in the CSF? That's an immune response. So normally we would say low white blood cell count is normal. In an HIV positive patient with a low CD4 count, low white blood cell count does not rule out any type of infection. Okay. More recently, there's been a move towards screening for cryptococcal meningitis. And so if someone comes in and has a CD4 count of less than 50, in sub-Saharan Africa now, where they have a lot of cryptococcus, it's common practice to get a cryptococcal antigen. And if their titer is greater than 1 to 8, they get treated, and they get treated with fluconazole. What happens when you don't treat them? Well, a significant portion of them go on to get cryptomeningitis and die. So if someone comes in with a low CD4 count, just check their serum cryptococcal antigen, and if it's positive, you can treat them and treat them with fluconazole. Okay, so how do we treat cryptococcal meningitis? So for meningitis, we use amphotericin B, up to 0.7 milligrams per kilogram, or we use ambisone, which is a liposomal form of amphotericin, and use that plus or minus flucytosine. More commonly now, the move is rather than using flucytosine is to use fluconazole. So amphotericin B plus flucytosine or fluconazole. The reason why flucytosine has been used a lot, wait, let's back up. So flucytosine was used a lot in the past because it was a drug that had been around for a long time and shown to be effective. But there's a problem with it. This drug is excreted by the kidneys, and it causes bone marrow suppression. And so now you're giving it with a drug that interferes with excretion through the kidneys. So there's a lot of toxicity that occurs. So now what's been shown is that instead, if you use fluconazole with that instead of the amphotericin B, that you'll get a better response. But so get treated for 2 weeks with this, and then follow that up for at least another 6 months with fluconazole at a level of 200 milligrams BID. If someone is not severely ill, they have a little bit of headache, they can take PO, you find cryptococcus in them, you give 400 milligrams for 8 weeks, okay? And then after both of those, you give fluconazole 200 milligrams for 14 weeks, all right? So we want to treat people for about 6 months, but it's what we found over the years is that people do the best when they get amphotericin B, okay? And it's very rare in the United States that we would treat people with fluconazole. Now, one of the problems that comes up is that people with cryptococcal meningitis, they have increased intracranial pressure. And by that, what I mean is that you, they may be obtunded, and then you do the LP and you put a manometer on them, and their pressure goes greater than 250. And this shows you the numbers of deaths that occur based on what people's opening pressures are. And you can see that that death rate goes up. The more people, the higher the opening pressure is, right? It goes from 21 to 27 to 38%, okay? So if someone has a high opening pressure, it's important to keep an eye on that person. And there are several things that you can do about that. In general, if the person, after you've done the LP, if a person has a high opening pressure, they'll say, oh, my headache feels better, okay? In some patients, even though the opening pressure is really high, they never get a headache again, and they feel fine, in which case you leave them alone, okay? If somebody's opening pressure is really high, and then 3 days later they get that headache again, they have a problem with opening pressure. They have a problem with increased pressure. So you do another LP, and they say, oh, I feel better. And so sometimes we do serial LPs on patients every 2 or 3 days, depending on when they are having symptoms, all right? In some cases, the symptoms don't go away, and in which case they need to either have a shunt put in by a neurosurgeon, or anesthesia will sometimes put in a lumbar drain. And the nice thing about a lumbar drain is you can put it in, you can take it out after about 3 to 4 weeks. Now, you're thinking, oh my God, put a drain in someone's CSF? Yeah, you're right. That's a good thing to think. Because they are at more risk for having an infection with that. So it's not something you do lightly. Most people will do just fine, but you will have these patients who keep having headaches, in which case they do need to be evaluated for high opening, for high intracranial pressures. Okay. So we talked about how we treat it. Yep. So that's that artist you saw. This is my son. That's one of his first things he did when he started art school. Okay, and it's called stippling, where basically what they do, it's actually drawn by dots. Every one of those pieces of black thing is a dot. But this is one of his latest pieces that he's doing with a guy to develop they're developing a game, and this is going to be one of the characters in the game. So I'm proud of him. I'm still waiting for the time that he can make some good money at this instead of being a starting artist, but it still gives me an opportunity to show it. So with that, I'll stop. I'll take any questions, any comments, any arguments. I once said that, and someone got up and started yelling at me.
Right. I don't. Cordella, do you have any questions?
I'm thinking.
Yeah, okay. No, that's fine. Look, I know this is the first time some of you have seen any of this stuff, and that's okay.
Sure.
And the key is, we keep going over it, and so you're going to hear it over and over and over again in different ways.
Okay.
And it's still not going to make sense until you start seeing patients and you start seeing the stuff, right? And so when we have you come down here and do some shadowing, you're going to see the common stuff. Who knows whether we'll see some really sick patients or not. I have no idea what's going to walk through the door. But you'll see the very common things, and that's really what we want you to get comfortable with. And for some of these other things, it's basically just if you get to the point as you're starting off as a recognition of, gee, this isn't right, if you can just get to there, there's something wrong here. That's pretty good. And if you get to the point where this isn't right, I think the guy may have something going on in his head and we need to get a CT scan and look for things, and that's great, okay? And that's just going to take time, and we'll just keep redoing it. Next week is Sam, is that right?
Yes.
Yeah, so Samantha Robinson's going to talk to you about case management, and then after that, I think we're going to have Dr. Patel talk to you about primary care. No?
She's the week after that.
She's the week after.
She's April 13th.
Okay, I got to figure out who's coming who's coming in 2 weeks. But particularly on some of the things that I've talked about already, about things like prophylaxis and starting people on antiviral therapy, she's also going to reiterate a lot of those things. So, you're going to hear it 5 different ways, and hopefully it'll start to make sense.
That sounds great.
Dr. Keiser,
Yes, ma'am.
this is Cordella. Is an MRI recommended for CMV diagnosis?
Not for CMV. No. So
It's for Thank you, sir. A lot about this. Thank you. Thank you. Good, thanks.
No, I'm going to say, so we talk, there's different ways we can talk about this, and later, if you want to, we can talk about more syndromic approaches. So today we've talked about it. This is how you diagnose each infection, and in some ways, it's a very artificial way of doing it, because someone doesn't walk in and say, I have CMV, and then you go, oh, check, 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 right? What happens more is somebody's confused. Someone has problems with their vision, right? So for CMV, definitely for the eye, generally you don't need an MRI scan. You just need to have somebody look in their eyes. But as we go through this whole cycle and you think about how you'd like to approach it, we can definitely do things from more a syndromic approach, which gives you a different way of looking at it that reinforces things. And as you start seeing patients again, I think that you're going to have tons of questions, and it'll come up that, oh, we really need to talk about this at one of these lunchtime things.
Okay.
Okay.
Thank you.
All right. Talk to you guys later.
All right.
Bye-bye.
Thank you, sir.
All right. Bye.
Bye-bye.